don't shop around. When you're eligible for a vaccine, get it. Don't worry too much about the brands and everything else.
Patients infected with Delta have literally 1,000 times the amount of virus in their nostrils. So they are spewing it out, and it's airborne.
Does the flu shot give you any protection against COVID-19?
From the Zoomerplex in historic Liberty Village, the Zoomer with Marissa Lennox.
Welcome to the Zoomer. I'm Marissa Lennox. Flu season is very much in full swing, and this year experts warn it'll make a comeback, particularly as COVID-19 restrictions lift. The good news, our viewers are diligent and have lots of questions about the flu shot, COVID boosters, and how to prioritize their health this season. We've been hearing from Zoomers right across the country for days, and so we've invited medical experts to the roundtable to answer their questions. But before we dive in, let's tee up the topic.
It starts with a cough. Then body aches set in. It could even land you in bed for a week. Welcome to flu season. Some say it didn't come last year, with only 79 confirmed cases reported, largely due to pandemic measures keeping the virus at bay. But any other normal flu season would average 54,000 cases, 12,200 hospitalizations, and 3,500 deaths in Canada. And experts warn this winter's flu could spike back. With more than 87% of the eligible population vaccinated against COVID-19, some regions are beginning to ease their public health measures, the very measures that stopped the flu in its tracks last year. So, will Canadians heed public health advice to get the shot? And could mask wearing be the new normal during flu season?
All right, we've got lots of questions. Are you ready? All right, let's get to it. The first one comes from Henry.
Hi, I'm Henry from Toronto. I'm 54. I am wondering about this year's flu season. I've heard that it could be worse than ever before. What do you think?
Professor.
Yeah, I mean, I don't think it's going to be worse than ever before. We've had some really bad flu seasons. I think we still have enough protection in place that kind of people are wearing masks and you know, it's going to protect us against respiratory viruses. That being said, I think it will be worse than last year. And we have some data now out of the Southern Hemisphere. They've already had their flu season, and I think they've experienced kind of a worse flu season than in the years prior as restrictions started to lift and whatnot. I think what's important is people get vaccinated, and what I'm seeing this year is it seems like we had an initial kind of run at the vaccine, and it slowly started to die off, which I didn't see last year. Last year I saw huge demand for the vaccine. So I think all of this stuff is there's gonna be an interplay, and we'll see where it lands.
But is there any truth to this idea that because we didn't have a flu season last year, Dr. Gorfinkel, that there's this immunity deficit?
A major difference is kids. So kids had no school yet last year, right? Businesses were closed. If kids were not exposed to influenza last year, they will not have built the immunity to influenza, nor will they have built the immunity to the many cold viruses that are out there. So yeah, their deficit is 1 year of immunity that they would have had they been to school. And so will that spell out a worse year? Quite possibly.
Well, that's what many people are saying. All right, let's get to the next question. It's from Colleen. She writes, how effective is the flu vaccine this year? What do we know about it?
We can only know that in retrospect. That's not a prospective question. That's not a question we could ask today for tomorrow. We can only know when we look back.
Okay.
But the World Health Organization takes a look at what happened in New Zealand, what happened in Australia, in the Southern Hemisphere, in order to come up with its recommendations of what strains the flu vaccine should have. And what's interesting is that the high-dose flu vaccine this year has 4 strains, not 3 strains like it had last year. They're coming down hard on, let's spread that out to 4 different strains, and that's what's so exciting about this year's flu shot. You've got an extra strain in there.
Okay, thanks, Colleen. The next question comes from Alfred. Go ahead.
Hi, my name's Alfred. I'm from Toronto. I'm currently 64 years old, soon to turn 65. I'd like to get my flu shot at the local pharmacy, but I'm concerned about the availability of the high dose, or whether they'd have it there or not. Can I get the high dose at my pharmacy? Should I call in advance? And if they don't have the high dose, should I just get the regular shot instead? What do you recommend?
John?
That's a great question. It's a question I field every day. If you had asked me this yesterday, I'd say, yes, we have high dose available. You asked today, we don't. The challenge with the high dose vaccine is they're distributing it to pharmacies kind of in smaller aliquots this year. So we run through it very quickly. Doesn't mean that we're out for the entire season, but it may be you come into a pharmacy that day and we don't have it. And that's the challenge kind of we're experiencing right now. That being said, I'm urging kind of, especially our higher risk seniors, not to shop around. If you're in the pharmacy, and we definitely have quadrivalent vaccine, I'd rather you get it now than wait 2 or 3 or 4 weeks later to come get the vaccine.
For the high dose.
For the high dose, yeah.
You recommend calling then in advance?
Yeah, I do recommend calling, but a pharmacy now has become a very, very busy place. And what I hear from my patients is I can never get through. And that's another challenge because pharmacies have gone from just offering vaccination now to doing all these other things. We're offering rapid antigen tests, PCR tests for travelers, filling the prescriptions, asymptomatic testing. So all these things, they've made kind of the pharmacy the destination, I think, for COVID, really. And it can be a challenge to get through at busy times. If that happens, try to maybe come into the store, deal with the staff. I think it'd be a little bit easier.
What about a doctor's office? I mean, do you guys have the high-dose flu readily available?
We had it and we're out of it. We also ran out. But my messaging to patients is this. What is high dose anyway? It has 4 times the amount of antigen, but is it really 4 times as good? And the answer is no, it is not. You have about a 25% reduction in influenza cases. So what matters more is getting it on board, because it's going to take 2 weeks from the time we're vaccinated. Hey, that's a familiar number. We heard that with COVID too. It takes 2 weeks from the time you're vaccinated to have any benefit at all from that vaccine. So what matters more is get it on board early so you're protected.
All right, the next question was emailed to us from Karen, and here's what she writes. Other than a sore arm, I've not previously had a reaction to the flu shot. This year, I happened to be at my pharmacy just after they'd received the first flu shots and got the high-potency shot for seniors while I was there. My arm was significantly more sore than with previous shots, and I also had a rash over a fairly large area of my bicep. This took a few days to disappear, was not overly itchy. Is this cause for alarm?
Absolutely, it is not. If anything, it's a cause for celebration. And why do I say that? I mean, it's a sign of a healthy immune system that it's reacting in a way that one would predict that it would react. So I'm not sure whom to worry about more. The person who has zero reactivity at all? Well, heck, is that immunosenescence? Possibly. Because we know is that as patients get older, their reactivity actually does get less. Younger patients with more robust immune systems are more likely to report redness, soreness, and systemic problems such as fever, joint pains, and muscle aches after getting vaccinated.
I mean, we see the common things, a little bit of injection site reaction, maybe some malaise over the next 24, 48 hours. That disappears. I mean, we've in my pharmacies, we've given over 20,000 immunizations over the last kind of year and a half. This is staggering numbers, and I haven't seen one serious reaction. Have you seen minor things? Absolutely, but nothing that I would consider serious. So the vast majority of patients that get immunized are going to do well. It may affect them for a day and a bit, but other than that, they get back to their normal daily life.
All right, we need to take a short break. We'll be right back with more of the Zoomer.
Pre-existing lung disease begets more lung disease. So if I have influenza, I am more likely to have COVID-19 and have a bad outcome.
Welcome back to the Zoomer. All program will be answering your questions about the flu and flu shots, so let's get back to it. The next question's from Deborah, and she wrote it by email. She writes, should every senior get the high-dose flu vaccine, and what are the risks? You're both nodding, so let's start with you, Professor.
So right now, the way kind of the guidelines are set up, for the high-dose flu is reserved for seniors with comorbidities. So if you're a senior, otherwise healthy, and you don't have any other comorbidities, things like diabetes, hypertension, cardiovascular disease, we want to reserve the high dose for those kind of more at-risk patients, and that's the way we're distributing it in the pharmacies. That being said, they could all get the high-dose vaccine if it's available. Our challenge now is availability.
Are there any risks, Dr. Gorfinkel?
The high-dose response is, I have not found it to be any different this year than the regular flu shot, frankly. And understand that the data comes from 2014. So we're basing the slight improvement of 25% on data that's actually pretty ancient and on data that involve different flu strains than what we have now.
Oh, I didn't
So we
realize
can't
that.
actually be even 100% confident that in fact you get the higher dose and therefore you get a better response. That is not a given. So let's undress that right here. What matters the most is that you get the flu shot and you get it on time. That's what matters. Because if you're looking at, oh, I've got to wait a couple weeks to get the high dose, or do I take regular dose now? The answer is clear. You get the regular dose sooner so that you have that immunity.
What does on time mean for you? When should people be getting it?
Now.
Yeah, and
Jinx.
Dr. Harris's point is, I've seen way too many senior patients with risk factors that are passing on it. They're coming in, they're asking me, hey, do you have high dose flu? I don't have it. Well, I'll come back. What does that mean, right? And it's way too many. I would say half of them right now are electing not to get vaccinated and to wait. And we're already in November, right? So how far are we going to take it? And I think, what I'm trying to convince everyone in there is get vaccinated now with the vaccine we have available. You'll be fine.
Mike has the next question. Go ahead.
Hi, my name is Mike. I'm from Barrie, Ontario. I'm 60 years old, and my question is, does the flu shot give you any protection against COVID-19?
John.
Well, that's a good question. I mean, I get asked that a lot. I think there is a little bit of evidence, and Dr. Harris, you could add to this, that it may add a little bit of incremental protection. We know patients that have had COVID are at risk for secondary infections, typically from influenza B as well. So, I mean, is it adding incremental protection? Maybe a little bit. The reality is you want to get vaccinated for both conditions individually. I mean, you're not going to have a ton of added protection. And I'm finding patients, because they've been recently vaccinated for COVID, are a little bit hesitant to get the flu vaccine now. And I'm seeing this in practice. Well, I just got 2 vaccines. They're telling me to come in and get my booster. I think I'm going to hold off. And I think that's really what I don't want to see. I want to make sure we vaccinate for both of the different viruses and get like the optimal protection, best protection as possible.
Actually, let's address that right now, because we had quite a few questions that were basically about that. Can you get both shots at the same time? Is it safe? Are the adverse reactions, will they be worse if you get both at the same time? Is there any benefit to spacing it out?
So 2 different questions. I'm going to answer the first one. Pre-existing lung disease begets more lung disease. So if I have influenza, I am more likely to have COVID-19 and have a bad outcome. When we look at hospitalized patients with COVID-19, is it pure COVID-19 that's found in their lungs? Absolutely not. They often have streptococcal disease. They have pneumococcal disease. They have influenza in addition. So when you protect against one, you're protecting against all of those other things, because one sets the stage for the other. And that's a serious problem. So, yes, you can give it. The National Advisory Committee on Immunizations, the federal body that recommends what provinces and territories should do, said 2 weeks ago already, they can, in fact, be co-administered. The flu shot and any of the COVID-19 vaccines can be given simultaneously. And what's fascinating is that there's work being done as we speak on just that combination in one shot.
Yes, actually, that's our very next question. So let's go to Stephanie.
Hi, my name is Stephanie. I'm 35 from Toronto, Ontario. I read that Novavax is looking at combining the flu and COVID shot into one. I was wondering, how much do we know about this? How far along are they in the trials? And do you see any benefits or drawbacks in combining the two?
It's definitely coming. I don't know. We're not going to see it this season. I'm not even sure if we'll see it next season. The other aspect of this is coverage, right? So there are many flu vaccines available. They're not all covered. So generally what happens is the vaccines will go on the provincial formulary, and as patients come in, they're getting the vaccines that are eligible for coverage, because it's free in the province of Ontario, right? And most of the country. So we have other flu vaccines that are out there, but you just can't get them. And occasionally I get asked for them, but they're not eligible for coverage. So I think we're going to have to wait and see how this is all going to play out. But I think this year, it's what we have. That's what you're going to get. And this adds to the fact that this is the first time in my career over the last 2 years, patients are doing a lot of shopping for vaccines. Yeah. Historically, that never happened.
That's such a good
People
point.
would come in and say, oh, here for my flu shot. No one would ask if it's high dose, low dose, quadrivalent. They didn't know, right? Yeah. But I think the environment that COVID created, between Moderna and the Pfizer vaccine, now that's kind of permeated out to all other vaccines. And people are so, so interested in which version of the vaccine they're getting. And I think the reality is that we've been trying to hammer this point down, get vaccinated as early as possible.
All right. Well, on that note, we'll be right back with more of the Zoom.
People feel that if they've got one dose, they're somewhat protected, and that's okay. Because I've asked patients, but they don't get it, that you can still get very sick, even die with a single dose, and we see that with COVID.
Welcome back. If you're just tuning in, we've devoted today's show to answering viewer questions about the flu and flu shot and other vaccines. Now, before we get back to it, I just had a question. What are some of the other adult vaccinations that people should be thinking about, in addition, of course, to flu and to the COVID booster at this point?
Hugely important. So this is for individuals over the age of 50. Every one of them should get the shingles vaccine. That's Shingrix, and that includes people who have had shingles. That includes people who have had previous vaccination with Zostavax. So if somebody had it like in 2015, that's probably the old one. Now, what are the other vaccines? There's the pneumococcal vaccine, and there are two of those, Prevnar 13 or Pneumovax 23. The government of Ontario will cover individuals 65 and over for Pneumovax 23, one dose. Why is that so important? Because it reduces the likelihood of getting invasive pneumonia, especially in the hospital. And it also reduces community-acquired pneumonias. This is what I call low-lying fruit. Imperative that people get vaccinated. Because as I mentioned, one disease sets the stage for the next.
Well, and also we were talking about that sort of baseline immunity that you get from the flu shot. That one question about does it protect you against COVID, can the same be said for the pneumococcal vaccines?
Absolutely.
We actually just published a paper. We looked at about 600,000 patients. Dr. Iris, if you have more than one dose, any vaccine, guess what percentage of patients will complete the regimen? And this is new data, and Canadian data.
75%?
Way lower, 32. So patients are getting their first dose, and then they're not coming back for their second or third if it's a 3-dose, right? And this is important because to get maximum immunity, you want to get all 3 doses or all 2. Shingrix, for example, you mentioned Shingrix. We looked at that data, only 42%, I think.
That's horrific.
What do you think the reason is?
Is
Is it because of adverse reaction to the?
We explored that in the paper, and some of it is that they had we know Shingrix can give you kind of a sore arm, for example, and maybe that bothered them the first time, and they said, I'm good with one. A lot of it is people feel that if they've got one dose, they're somewhat protected, and that's okay. Because I've asked patients, but they don't get it, that you can still get very sick, even die with a single dose. And we see that with COVID, right?
Let's not delude ourselves. That's part of the picture. But the other part is cost.
Yes.
So for many people,
Absolutely.
Shingrix, it's a super expensive vaccine. So affordability is a thing. And then, of course, we know that reminders, especially automated reminders, work, and they work really well.
All right, let's get to the next question. It's from Tilda, and she writes, when can we expect a vaccine for COVID-19 and variants that will give an immunity for a few years and not cause allergic reactions, blood clots, and affect the heart muscles? Now, this has been sort of the biggest deterrent, I think, for those that are apprehensive about getting the COVID-19 vaccine. It's those blood clots and inflammation around the heart and whatnot. What do you say?
Absolutely. So a few things about myocarditis. How common is it? Answer, extremely uncommon, but common enough to take notice of. So it's an important signal. It's the kind of signal only large real-world data tends to show. We know it's more common in men. We know it's more common after the second dose, which makes you wonder, what about the third dose? What's going to happen if young men are going to get that third dose? Answer, we don't know just yet. However, we know the harms of myocarditis from COVID-19. We know the harms of blood clots from COVID-19. And guess what? If somebody has COVID-19, the likelihood of their having a blood clot is 10 times higher. Check my work. 10 times higher than that of any of the vaccines.
Is that in the general population or in older adults?
This is in the general population.
That's a good point. All right, another question that came in by email is from Vivian, and it reads, can a doctor refuse an office appointment for a non-vaccinated person? Doctor?
I'm so horrified by that question, and I'm also kind of almost personally hurt by it. And the answer is absolutely not. I would never do that. Everyone is welcome, whether or not they're vaccinated. And it just makes me shudder because I really feel viscerally that the conversation has to change. I am done with anti-vaxxer versus vaccine hesitant versus Iris Gorfinkel. Guess what? We are all one person. And why do I say that? Because we all want fewer cases. We all want fewer hospitalizations. We all want fewer deaths. And we're all scratching our heads asking the same question. Is this safe for me? How frequently should I get it? When should I get it? And those are questions that we share. And I think it starts with a commonality. There is nothing in medicine that has ever worked with a divisive, tribalistic nature that these kind of language that we're now seeing is promulgating.
All right, thanks, Vivian. Stick around. More after break.
On the one hand, you have the risks of the vaccine, but let us not ignore what's on the other side of that scale, the risks of the disease itself.
Welcome back to theZoomer. All right, before we get back to the questions, I had a question of my own, and it's, when they started to roll out the COVID-19 boosters, they initially approved it for people 70 and older, people who were immunocompromised. There was also this group of people who had had 2 AstraZeneca vaccines, but got approved for the booster. In some cases, these are 30 and 40-year-olds ahead of 65-year-olds. I mean, what's the logic there? Does that suggest that the AstraZeneca vaccine wasn't effective? I mean, and then you wonder why people are vaccine shopping. Well, it's because of things like this.
Yeah, this is confusing, and it has been confusing, I think, for everyone. And it depends where you are across the country. There's provincial variation. I can speak for Ontario. In Ontario, we initially started with the immunocompromised patients, so patients that were on certain medications or had a condition that made them immunocompromised. We're at the point right now that if you're over 75, you're eligible for a booster if it's been 168 days since your second shot. If you live in a congregate setting, if you've had 2 AstraZeneca doses, you're also eligible, irregardless of age. So there's these subgroups that now qualify. But it has made it confusing because I have patients that will come in assuming, I'm a senior, I have risk factors, can I get the booster? It's been, 200 days. No, not yet.
But what's the deal with the 2 AstraZeneca doses? Why?
AstraZeneca is just not as effective as Pfizer's vaccine. And because of that lesser efficacy, the concern is they will have more breakthrough infections despite having been vaccinated. Now layer Delta on top of that, and that becomes a serious problem. Patients infected with Delta have literally, I'm not exaggerating this, 1,000 times the amount of virus in their nostrils. So they are spewing it out and it's airborne. So, and never mind, a significant number of them, we're not sure, it may be 40%, are asymptomatic. They look totally fine. Mm-hmm. They look like I look right now. You would not know. So I'm just saying.
And you can still spread when you're asymptomatic.
Absolutely, there is asymptomatic spread. And never mind, that's true not only for COVID, that's true for influenza, that's true for the common cold. The big difference is when it comes to influenza and common cold is they, in fact, are spread by surfaces.
One of the things that sort of plagued the rollout was this lack of supply, John. What do we know about the future of booster shots and their availability?
Oh yeah, and we lived that lack of supply. It was very consistent at the beginning, even towards the middle. We have tons of vaccine now. There's a lot. I haven't seen a limit to the amount of vaccine. So I think Canada's in very good supply. And the message here is if you're eligible for your booster, go in and get it. You're not going to have to wait. We have the vaccine, both Moderna, Pfizer. I would even suggest open it up. We have that much vaccine right now. I haven't seen a situation where we've been running out.
All right, let's get back to the questions. Our next question comes from Debbie, and here's what she writes. I'm 66 years old. I'm also a primary caregiver for a 90-year-old mom in long-term care home, having already had 2 doses of Pfizer, and am up to date on high-dose flu, pneumonia, and shingles vaccine. Good for you, Debbie. Do you think it is really necessary for me to go for a 3rd Pfizer booster shot if offered to me?
1,000% slam dunk, yes, no hesitation there. And why is it important? Because we know immunity wanes over time. And again, the data from Israel and the data from California is extremely clear on this. You hit the 6-month point after you've been vaccinated with your 2nd dose, and your immune efficacy drops to 45%. And why is that a problem for somebody going into a long-term care home? Yeah, they're probably not going to get hospitalized themselves from the disease. They're not going to have severe COVID, but can they transmit it? Yeah. Yes, yes, yes. And that's why it's so dangerous.
All right, thanks, Debbie, for that question. The next one comes from Jeff. Go ahead.
Hi there, I'm Jeff. I'm from Toronto, and I've never taken the flu shot. I'm 48. Should I start now?
Absolutely. Yeah, I mean, everyone should get the flu shot.
So the flu shot's not just for the young and the old. It's for everybody in between, too.
And, I hear this all the time from my younger patients. Well, I'm going to get the flu. I might be knocked out for a week or two, but nothing more serious is going to happen to me. The reality is, possibly, you're probably right. You're probably not going to end up dying, but you can pass it on to others, other high-risk patients, the very young, the very old, the immunocompromised. This is how we get these outbreaks. So the reality is, do the right thing, get vaccinated. We should all get vaccinated. It's available. There's so many access points now. There's not really an excuse.
All right, let's head to the next question. I saw him earlier. Rick, go ahead.
Hi, my name's Rick Baker. I have the pleasure of serving as the president of CARP Ottawa. I keep hearing that there's still a lot of confusion about how the vaccine, the COVID vaccine most specifically, and now we have the flu vaccine. How do I know its importance, but overall its safety factor?
Oh, great question. So we're informed about its safety from two main sources. The companies themselves, and everybody says, well, the companies have every financial reason to tell you why they're safe. But at this point in time, COVID-19 vaccines are one of the most studied vaccines of all. So if you take a look at how many doses have been given, it's in the billions at this point. So when we talk about safety, we have our magnifying glasses on trying to find those extremely weak signals, including unusual clots, including myocarditis. We're looking at it with such a fine-tooth comb. The risks that we accept in our daily lives far, far exceed the risks of these vaccines. And moreover, they have to be compared to the risks of the disease themselves, which many people seem to conveniently put aside. Like any medication choice, things are put on the proverbial scales of justice. She's got that blindfold on and she's holding the Libra scales. On the one hand, you have the risks of the vaccine, but let us not ignore what's on the other side of that scale, the risks of the disease itself. 10 times the number of blood clots associated with COVID-19 versus any of the COVID-19 shots.
All right, the next question is from Donna. She writes, some friends are not getting the COVID vaccine because they say some of their friends died having the vaccine or had blood clots. What are the numbers of people that have died in Canada from having the COVID shot or died of the vaccine or blood clots?
Do you know the number of patients that have died? I don't know off the top of my head.
As of October 1st, there were 6 cases that were proven to be related to the vaccine. And I want you to compare that to the 75% of all Canadians plus who've now been vaccinated. So what we have, and this is a big problem for Health Canada, you've got this many reports, but when they really look at the data and say what is truly related to the vaccine, that number shrinks down significantly. Because guess what? Blood clots are exceedingly common. And they're common for other reasons. They're common because of strokes. They're common because of medications. They're common because of comorbidities, like diabetes, smoking, high cholesterol levels, elder age. So it's actually really difficult to tell, is it necessarily from the vaccine? That's a big statement. The ones that have truly been confirmed as of October 1st, numbered 6.
And I'll tell you, and you said 6 patients. I've had in my practice that I know of, and this is my own practice, 12 patients that were hesitant, didn't want the AstraZeneca vaccine or didn't want the Pfizer or Moderna vaccine that have died of COVID. These are patients that I've known, long-term patients of mine, husband and wife, had a relatively young patient, and that's just my practice. So we know, the number of global deaths is 5 million, I think, now due to COVID. So your risk of dying from the disease is so much higher. I don't think anyone knows someone that hasn't been impacted.
All right, it's great points there. There's more after the break. Don't go away.
Rapid antigen testing will not pick it up. There's no photocopier effect happening. PCR, photocopier. Small amount of virus, you're going to pick it up.
Welcome back to the Zoomer. Today's program is all about answering your questions about the flu shot, COVID boosters, and more. The next question comes right from our live audience. Marilyn, great to see you. Go ahead.
Hi, my name is Marilyn, and I'm from Calgary, Alberta. I'm in my late 70s, and I just had my booster shot for COVID. And I'm wondering, are we seeing, or is it too early to see, any breakthrough COVID cases after booster doses? As my brother and his wife, who are in their mid-80s, have just had COVID after a double dose of COVID vaccine.
Yeah, I think in Canada, anyways, it's going to be pretty early because we literally just started giving the booster shots. Any international data that you're aware of?
So what we know is that that booster shot gives 95% efficacy against getting disease. Note, it is not 100%. Will there be breakthroughs? The answer is there will always be breakthroughs. There will always be individuals who are either immunocompromised and still don't amount to a good enough response. There will always be individuals who are older with comorbidities, who are on medications or whatever, that they simply are not mounting a good enough immune response. So when we talk about vaccination, we never talk about perfection. Yes, there is always potential for harm. But that harm, and the harm of the potential for breakthrough infections, has to be weighed against the harm of COVID-19. At this point, 95% efficacy is pretty good. Will it last forever? We don't know. It's probably going to be a three-dose series, but time is going to tell us that with real-world data.
And then, Marcy, things have opened up. People are starting to travel again. We do a lot of the travel testing, so I see it in my pharmacy. People are flying around everywhere. They're going down to the Caribbean. They're going down to South America. We're, a variant away from kind of having a real issue again, right? So that's a real possibility. I mean, we could be exposed to, a variant that's from another part of the world, and all of a sudden, we're rethinking the entire kind of vaccine process.
There's a good reason why Health Canada is sticking to its guns and saying travelers have to be tested prior to coming to Canada, because bringing that variant of concern in is a real concern.
All right, speaking of testing, actually, we do have a question from Simon on that very point. Go ahead, Simon.
Hi, my name is Simon and I'm just over 60 years old and I am happy to live in Toronto. My question is, before we travel, we always need a negative test, a COVID negative test up to 72 hours before traveling. What is the significance of 72 hours and could it possibly be 96 hours or 120 hours?
The reason it's 72 hours has to do with the virus itself and how it interacts with individuals. So if we were to make it, say 24 hours, the problem is the viral load in a person is too low at that point. So what happens at the 72nd hour, that gives us the best opportunity to pick up the virus from the nose when we test. So why not make it 96? Because they've had that virus on board already for a couple of days. So you want to hit it at the point where you can pick it up, and yet you're not going to have too many cases. So PCR, why is that important? PCR stands for, in my mind, photocopier. Because if there's hardly any virus there, your PCR testing is going to copy that. And so you can see tiny signals. That's in comparison to rapid antigen testing. Very little virus there. Rapid antigen testing will not pick it up. There's no photocopier effect happening. PCR, photocopier. Small amount of virus, you're going to pick it up. 72 hours is that golden time.
And I think it's important because I get a lot of questions from patients not understanding the difference and not knowing when to get which test. If you're traveling into the US, you're okay to go with a rapid antigen test. If you're traveling to certain European countries, you need PCR. So you got to be aware of what type of test you need before you go. When you're coming back into Canada, you need a PCR test. And it's not always easy to get in some of these other countries. So you have to pre-plan a little bit, especially if you're going for a short trip, because you got to figure out, hey, where am I going to get that test within the window and get back?
All right, the next question comes from Lois, and here's what she writes. How come doctors, the government, WHO, the CDC, and so on, are not looking at all the peer-reviewed science about the efficacy of the COVID shot? As science is never stagnant, but rather a collection of observations, would you not expect true scientific studies to be seriously collecting all data for and against to be able to give an honest account of risk versus benefit outcomes?
Here I greatly push back. I think some of the finest medical minds are sitting at the CDC. Some of the finest medical minds are sitting at Health Canada and at NACI. They eat, breathe, drink, and smoke COVID. It's coming out their wazoo. And I just say, like, I can't even listen to that question without pushing back with every fiber in my body. Really, I hate to tell you, but they are, in fact, looking at all the data. If it's good quality data, that is. And we know there's so much misinformation, and I hope to God they're not looking at that misinformation that's out there.
And I think it's important to say that things were changing so quickly at the beginning that decisions were being made based on the best available data. And that was causing a lot of confusion. But, you know, we got more data, decisions were made differently, right? And that's why we saw all those changes early on and what the guidelines recommended and what was happening with respect to adverse effects, because we were learning as we were going.
All right, we need to take a short break. There's more when we return. Welcome back to theZoomer. There's been a lot of information thrown at you today. Hopefully you found it useful. We have just a few minutes left, so we'll get to the next question. Steve, go ahead.
Hi, my name's Steve. I'm 37 from Toronto. My question is regarding personal protective equipment. So for the last 2 years, we've been wearing masks, and it's been really good at preventing spread of colds and flus, and I haven't caught a single thing. So my question is, going forward, should we be wearing masks during flu season?
Will this be a thing? I mean, I'm so over the mask, if I'm being honest. I'm just gonna be honest. I'm tired of wearing it, but will this be a thing going forward in flu season?
I think so. I think it's going to be a thing for a while. I think as restrictions relax, masks may be something that go away. But I think the public's been educated now. They've realized, exactly to his point, hey, if I wear a mask during a flu season, I'm less likely to get the flu or even the common cold, and we've all lived that now. So I think for certain situations, travel, congregate settings, sporting events, things like that, you're going to always see people with masks, at least for the next few years. I don't know what you think.
I'm so excited. I love the fact that masks have now become a fashion statement. I've got masks that say Gucci on it. Not that I'm really a Gucci person, but that's what they say. You know, and what's happened is that it's just emblematic of how it's become sewn into the thread of who we are. You can make a fashion statement with it, and yet you can still be your own person. And I love the messaging that it gives too. I care about you, you care about me, but it's graduated beyond that. I think we're gonna see it becoming a natural thing when people are sick.
So you think we need to embrace it. All right, the next question comes from Murray, and it reads, I know of a person, a family member, who contracted COVID-19 in August 2021. This person had not had any COVID-19 vaccine shots, still has not. My question is, if having had COVID-19, does that mean that he or she has a natural immunity to the virus going forward? And if so, then should there not be a test or proof for that immunity and an immunity passport given, similar to the vaccine passports now distributed for going into restaurants, so on and so forth? What do you guys think?
So what we know is that individuals who've had the disease have inadequate protection from COVID-19. So the vast majority.
So the immunity from the virus itself is worse than the immunity you get from the vaccine? Because there's been mixed messaging on that.
It's 1/5 the immunity. So if you take a look at how robust their immune response is, for one thing, what is the disease? It could be any one of the variants, and it could be any amount of viral exposure. And this is one of the big problems. They may have been asymptomatic. So what happens with a vaccine is that you have a fixed amount, you know exactly what that response is going to be based on large population data. Getting exposed to a virus is anywhere from a low viral exposure all the way to a super high viral exposure, from having no symptoms to having lots of symptoms. So this is the problem with natural exposure. The studies that have looked at that show a robust immune response, 5 times the amount after vaccination compared to natural infection.
Do we know how long natural infection immunity lasts compared to the vaccine immunity? Because we know vaccine immunity wanes after 6 months. What about natural infection? Does that last longer?
And we know the vast majority of patients have had mild disease, and the mild disease doesn't generate those memory antibodies that are important for more robust protection. And I'm able to measure this in my practice. Actually, we have the technology now where you can do an antibody test on patients, and I use it to convince them to get vaccinated because, well, I was vaccinated. So we do a test, and you see they don't have them. right? So they may have been ill, you know, a year and a half ago, but when we do the antibody test, they're not there, or they definitely don't have the IgG antibodies, right? So I think that's a kind of a loaded question that was asked there, but to try to police that would be very, very difficult.
Before we go, just circling back to influenza, let's just talk very briefly about who are the high-risk groups involved when it comes to influenza.
So the high-risk groups include children, and they are so overlooked in this equation, but shouldn't be. 6 months of age to 5 years of age, those are the ones who really wind up getting hospitalized from it. And why is that? It's simply because their immune response is not mature enough. They haven't built up the library of immunity. And that's a serious problem because lots of them did not even have any exposure whatsoever, never mind to COVID-19, but to influenza last year. So could it be a twin-demic for this group? Absolutely. So that's a hugely important group to get vaccinated. Then you have pregnant women. So pregnant women historically have been a high-risk group for influenza and for COVID-19.
All right, any final thoughts you guys would like to leave us with?
I love the accessibility I'm seeing in pharmacies now. I think to the degree that we're able to take down barriers to getting vaccinated is to the degree that we'll be successful at giving vaccines. The second thing I want to push back at a little bit is the lack of availability of easy testing. I'm deeply concerned about that. Not only for influenza, because such a test actually exists, but also for COVID-19. There's financial barriers to getting it. I don't even have it in my own office as a family doctor, and patients themselves, the finest physician in the world, cannot tell the difference between what a common cold is, which is 5 to 7 a year, that's far more common, what an influenza is, and what COVID-19 is. Bring on the testing finally and take down the barriers.
I think my point is, don't shop around. When you're eligible for a vaccine, get it. Don't worry too much about the brands and everything else. Listen to the advice of your healthcare provider. Get vaccinated as early as possible.
All right, that's all the time we have. Thank you to everyone who submitted their questions for this show, to the virtual audience for being here, to you at home watching, and to my panelists, of course. And don't forget to catch new episodes of theZoomer every Monday at 10 p.m. Eastern. We'll see you soon. For now, it's time to zoom out.